RAIN, popularly known as Ramachandra Advanced Interventional Neuroradiology, popularly known as RAIN. This is the 9th time we are organizing the conference ever since in 2013. And we have been extremely fortunate to have in this RAIN 2014 to have Professor Michael Mawad, who is the professor of neuroradiology and the chairman of neuroradiology from Baylor College of Medicine, Texas, Houston, who will be attending this RAIN conferences as well as participating as an international faculty in the RAIN 2014. We are extremely fortunate to have Professor Mawad with us. And so, what do you think that the RAIN will provide, or what do you think that the RAIN have the focuses on?
Actually, first of all, I'm very grateful that you will include me in the meeting. I look forward to coming to Chennai and participate in the RAIN meeting along with yourself and the other interventional neuroradiologists from Europe, as well as all our Indian colleagues. I think the RAIN meeting, much similar to the LINC meeting and other meetings that have been held over the years, both in the United States and in Europe, and to some extent in Japan and in China, are crucial meetings in terms of transmitting the information both through live cases as well as through didactic lectures and roundtable discussions as how to make the procedure safe, how to set the proper indication both for aneurysm treatment, for arteriovenous malformation, and for the treatment of acute stroke. I think it's very important that we relay this knowledge and this message to the young and up-and-coming participants, primarily to make the procedure safer and to make the outcome better for their patients. So therefore, a lot of devices will be discussed, the pros and cons of these devices, the proper indication, and the safe measures to take during those treatments. And I would personally very much like to have a nice discussions with the attendees on how to avoid complications and what are the various measures that one can take to make the procedure safer and the outcome better. So I look forward to participating with you in that meeting, and I'd like to invite everybody to come and to benefit from the concentration of expertise that will be in Chennai in November.
Apart from this, in India, the peculiar problem we have is 1.2 billion of population, and we also know that roughly around 12% to 20% will be hemorrhagic stroke, and the remaining 80% is ischemic stroke. So here in our country, the interventional newer techniques have not been established, and the stroke units are still in a primitive state. So how do you find that it has to be taken to the next level to give some balance of equations of treatment of ischemic stroke?
Actually, I'm glad you asked that. This is a very important topic, and we are fortunate in the United States that we've had some time already to have developed many stroke centers throughout the U.S., both primary and level 1 and level 3 stroke centers, and that requires a concentration of expertise from interventional neuroradiologists to neuroanesthesiologists to stroke neurologists, and also to a high level of intensive care unit, including neurointensivists and critical care neurointensivists. Also, it requires the setup of a telestroke unit that connects many hospitals with a centralized place where that level 3 stroke center exists. So I think we can, at least by discussing these topics and setting up goals and models of doing or accomplishing these referral centers and patterns of like the drip and ship pattern and the rapid response team for dealing with an acute stroke would help. I hope will tremendously help your country and India, because you have such a large population, and to do it effectively and safely, and hopefully at a reasonable expense to the government.
Basically, it also requires good cooperation between the clinicians and the endovascular technique alone will not give good results in, especially in the ischemic stroke. Basically, you require to have sensitization of the neurologist and the other clinicians and other persons involved, especially the transportation personnel, the emergency personnel, and several others. And I think that gives a big information on this particular aspect.
Absolutely. We hope that we can touch upon all these issues, like you said, starting with patient education in the community, going to the patient, going to the general population, giving them booklets, giving them pamphlets as how to recognize the early sign of a stroke, to the EMS and the emergency room services, to the local ER physicians, to the local neurologists and local neurosurgeons, the local cardiologist who sees a lot of atrial fibrillation and also that is also responsible for stroke, and to educate and prepare the next generation of neurointerventional experts into learning the safe procedures and using the proper tools for mechanical thrombectomy in conjunction with bridging with intravenous thrombolytics.
And appropriate medical management.
Absolutely.
It's absolutely essential to have a stroke unit without which if you stand independently it is going to fail. It's
Absolutely. Absolutely.
Yeah.
That's what we have learned in the United States actually.
So in addition to this, now we are trying to demonstrate newer devices here. So there are several techniques of stenting, which include the X stenting, the Y stenting, and different types of stenting, the horizontal stenting, linear stenting. So how do you rate these sort of procedures in the United States compared to?
Well, in my particular practice, I have been fortunate to use multiple stent-assisted coiling procedures, like you mentioned. A lot of bifurcation aneurysms are treated with Y stenting. A lot of anterior communicating artery aneurysms are treated with either X stenting or Y stenting. Even in sidewall aneurysm or regular aneurysm where the neck is wide, I tend, in my own opinion, I think stent-assisted coiling offers better results in the long term in terms of avoiding recanalization. So I would be more than happy to show my experience with this and go over the pros and cons of stenting, including the pros and cons of dual antiplatelet therapy. In addition to the other methods of treating aneurysm, primarily nowadays flow diversion, how to handle judiciously the antiplatelet therapy and flow diversion, intra-aneurysmal flow diversion with the new devices such as the Luna or the Web, for instance, and the treatment of wide neck bifurcation aneurysms. So hopefully the attendees by the end of the meeting will have an overall picture, both the positive and the negative of each of these techniques. But the primary goal is to make sure they leave the meeting with a good idea of how to set the indication for each location, each anatomy, and each morphology of the aneurysm, and how to take advantage of all the devices that are becoming available.
So it's also important to see that the complications have to be limited, because this is a minimally invasive procedure. We do have complications, but it should be kept to a limited set of things. So do you perform a lot of checklist on doing this, or how will you handle this?
Yes, absolutely. So I agree wholeheartedly with you. Sometimes we get a little bit carried away with using new devices and with wanting somewhat stubbornly sometimes to treat patients in a non-invasive way, and obviously we end up with problems. So it is important for people like us who have had at least in my case, who have had a fair share of complications, to share those complications with the attendees at the RAIN meeting, and to establish a way, or at least discuss ways or various ways, sometimes minor measures, sometimes major items, as how to avoid complication, be it having a checklist, having at least a set goal for each and every one procedure and not to move from that goal, and also most importantly, how to avoid the complications, how to avoid perforations, how to avoid thromboembolic complications, and whenever these things happen, what is the safest way of getting out of trouble. So A, try every measure not to get in trouble, but also if you inadvertently get in trouble, how to get out of trouble. It's not a solve-all panacea, but I think it helps the folks that are starting these procedures to keep their complications to a minimum.
It's absolutely important in the sense that any complex procedure has been broken down to simple step, and each step has to be carried out in a simplified fashion and written down in a particular form so that the results are coming in a good way. So that is probably the best way to see that it is being going well, and that is why I think you are also able to establish a good results in your own field. I think the youngsters should learn from the lessons learned by the experts in this field. And ladies and gentlemen, I think this should be a wonderful meeting. I think you should not miss this opportunity so that we have a joint day to have.
I look forward to coming to Chennai
and
participating with you and the other folks in the meeting.
Definitely, we are eagerly waiting for your arrival and then showing your results. Thank you.
Great. Thank you very much.